Caitlin, you had asked for announcements. We will soon be distributing information. On October 2nd, we'll be hosting a women's mental health conference. At UAMS will be in a similar format to what we have done before. It'll be a series of TED Talks, but this time we're also going to be doing a couple of workshops as well, trying to do things a little differently. So October 2nd, 8 to 2, be on the lookout for more details coming soon.
Absolutely, very excited about that. I went to the last deal y'all had at the Robinson Theater, the Robinson, with Cal's, and that was
Right.
very, very good. So I enjoy going to any of the stuff you guys put on.
Great. Well, we're looking forward to hosting it. When we did a survey of people that have attended our events, and women's mental health was the number one by far most requested topic. So
I believe it. And you said it's on campus at UAMS?
it will not be on campus. We're hosting it. We're working on the final details of getting that laid out. I just want everybody to hold the date. It'll be here in Little Rock.
Okay.
I'm sorry, Michael, would you just say the date one more time?
October 2nd.
Thank you.
If you keep me in mind, send me the flyer as soon as you get it. I'll send it out. So
You're always on the top of my list, Caitlin. So.
thank you. Okay. Any other announcements we've got before we should get started?
I guess on that note, also in October, but the next week, October 9th and 10th, the Arkansas Psychological Association is having their annual conference, and it's going to be more um, uh, facing mental health professionals, but also facing the public, and it's on suicide prevention and assessment for suicide. It's called Turning the Tide, Strengthening Hope, Connection, and Community. And they'll have there's a keynote speaker that's also going to be at doing the grand rounds at UAMS. And they're going to have some really neat things. So I'll send you that information too.
Please, yeah, that would be super helpful. Great. Okay, we were just talking about earlier this morning about getting our newsletter back up, which I fell behind a little bit. That is on me, but we usually are able to send out some of these upcoming events that way. We'll put it on our social media, send it out to our mailing list. So definitely get some wide coverage with that.
And just as a segue, so the Women's Mental Health and Suicide Prevention Assessment, CoCM can actually be very much a part of working with those populations, and especially having immediate psychiatric assistance for someone who is actively suicidal if that's needed. So very relevant to integrated behavioral health and CoCM.
Yeah, we had two actively suicidal patients yesterday that we talked to that I supervise our care managers. So helped with them, and then we actually just sent a referral for a postpartum depression that was recognized in one of our clinics. So we are actively working in those populations.
Glad your BHCMs were there. I'm sure that made a very, very big difference in that care. Okay. All right. I'm going to hand it over to Teresa. Is that okay? Okay.
Would it be okay if I share? I made a few slides.
Please do. Yep.
First, for some reason, it's not showing the screen I wanted to show. Let's try something. The one thing I have really not mastered, well, there's lots of things I haven't mastered, but one of them is this double screen in Zoom at the same time.
Yeah.
All right, let's see if we can.
Technology is the bane of my existence. Yes, it's necessary, but a challenge.
Early in my career, I kind of and why some of my colleagues who were older than me couldn't make a PowerPoint slide to save their bones. And I owe them a deep apology, because while I can make a PowerPoint slide now, the technology to share them with all of you kind of baffles me. So if you will forgive me, what we're going to do is we're just going to use this display, even though I'm sure I'm really supposed to go like this. But then you're probably seeing the wrong version, right?
Yeah, the presenter version.
So we're just not doing that. We're going to go with this, and I'm going to hope you guys will forgive me. So at any rate, I wanted to give you a little update of what's going on with us and why we're pretty excited about the project so far. Excuse me. One of the things I didn't put on this slide, however, is that we are working on a better name than the Arkansas CoCM project. We're almost 2 years in, and I feel like we're ready for the project to have a name and a little bit more identifiable personality. So stay tuned. We'll be bringing that to you fairly soon. So a bit of updates about what's up with sites. East Arkansas Family Health Center is coming along nicely, and they have CoCM implemented at one clinic. I think it's their main site, but I didn't manage to verify that. So as you can see, I didn't fill that in here. They've been enrolling patients since I believe February, and they have roughly 46 enrolled. If anyone is here from that clinic and I'm saying the wrong thing, please go ahead and correct me. Correct me. Tisha has had her hands full with the UAMS primary care and family medicine clinics across the state. From my point of view, there's about 33% of the 14 UAMS clinics have the program in place, and these include Pine Bluff, Texarkana, Helena, Batesville, internal medicine here in Little Rock, and Tisha is proactively reaching out to the other clinics to continue to expand. So, and they have 179 enrolled, at least on the report, my latest report. So these are our two longest standing clinics. They're doing very well. And so we're excited that we now have a fully executed contract with the Arkansas River Valley Medical Wellness Clinic. And many of you, in fact, all of you probably know a little about that clinic because it's somewhat unique in that it serves a lot of patients with substance use conditions and provides primary care for them. And usually you hear people, it's sort of described the other way around. We're a primary care clinic and we care for some people with substance use issues. But I like to kind of turn to say it the other way when I present this, because Dr. Martin, who runs that clinic, is in fact she was a leader in Arkansas in treatment of opioid use disorder. I believe she's up to 2 vans that she uses to help treat patients with opioid use disorder. So we're excited to have them come on board to embrace this model and use it to expand their services. SAMHSA is pleased that we are doing this because I'm sure if any of you have read an RFA from SAMHSA, they have their main thing they want you to do. And then there's these paragraphs that list everything else that they think would be good. And embracing clinics that treat substance use was one of the things that SAMHSA was kind of the top of their, and this would be good list. So we're really excited to have them. And then we're also about to finish I should say that Arkansas River Valley has already reached out to ABIN and is preparing to do some training and to start getting their case manager in place, and they are ready to create the contracts. I believe they're going to use the woven practice for their their psychiatric consultant, and they're ready to start working on that contract. Okay, so that said, we'll move to the McGee Family Clinic. They are also remained very excited about this. I have signed off on their contract. Mr. Amstutz has signed off on the contract, so that's important. UAMS still has a few other things it has to do before they consider it fully executed. And so we expect that McGee can begin working with ABIN shortly. They are very excited about enrolling patients in this clinic. I'm excited about the opportunity to work with this clinic in part, and this is just a personal interest of mine, but I'm very struck by the statistics on substance use and pain among farmers because they have sort of chronic injuries. And I don't know if any of you have ever seen any of the like ED memes about the ED doc who's like, oh, farmer, he's told farmer so-and-so came in and he's like, oh, is his wife with him? No, he was working a fence and his back hurt. Well, did he finish the fence? No, he just stopped and drove himself in. Oh my God. And they activate all of the whatever, including what they call it, the crash set, because they don't have a crash cart, you understand. And so, because their crash cart, it's a rural clinic. So, but my point here is that farmers are reluctant to get care, but there's a lot of need in that space. And McGee has a lot of agriculture workers. So I'm really excited to be working in this space and to almost have this in place. And by the way, if many of you don't know Mr. Amstutz, he's actually won many awards for the resources he's bringing to the McGee Hospital and McGee Family Clinic. So I'm really excited to have them engaged. And then I thought you might be interested in thinking a little about outcomes. I owe this slide entirely to Tisha Dean. Thank you, Dr. Dean, because she has been above and beyond going out to say, why does this matter? What impact are we having? And I really appreciate it. And so some of the information she brought forth to our team and to others is in a traditional model, sort of nationwide, to get to a psychiatry visit takes roughly a mean of 67 days. And it's better for telemedicine, 43 days, but still not great if you really have severe symptoms. In an APA survey, 56% of their respondents indicated they have no new patient openings. So even if you're willing and able and have the necessary means to pay for services, you still may not be able to access services. But the stats for UAMS CoCM program shows that on average, the time from PCP referral to a therapy session to meeting with a behavioral health case manager and or psychiatric consultation, depending on the patient's need, is roughly 11 days, although often the program can make that happen within a week. And 80% of the UAMS patients that are in the CoCM model, so those 170 so patients, are reviewed in the psychiatric case conference at least once a month. So it's a way to truly get care to patients in a timely fashion. And Tisha, I'm going to take the liberty in my next slide of sharing one of your patient cases, but I'm hopeful that you will just feel free to embellish and if any important information that you need. But one of the things that Tisha has really been helping us with is not only to send, we send a quarterly report to the state that is shared with the legislature. And Tisha has been helping us with having not only the numbers, and all the sites give us their numbers. Tisha's been helping us create these case presentations to give a more personal look at how this works in real life for a patient. And so we have Ms. K here, who is a 50-year-old Black female, presented to the clinic with obesity, hypertension, and is pre-diabetic. So she's having some problems. Her PHQ-9 that day was 17, which indicates symptoms that are consistent, that are moderate to severe depression. She did engage with a behavioral health case manager, and her initial assessment occurred, I know you sent me this and I left it off, within a weekish, 10 days, something, a relatively short period of time, which is important because it was so much better than we could have obtained with referring this patient elsewhere for mental health care. The behavioral health case manager worked with Ms. K and set goals. And the thing that I really like about this is for dealing both with Ms. K's concerns over mood, but also concerns over health. And so the first thing they did was stop smoking and improving and developing strategies to cope with family stressors. And these are resources the behavioral health case manager can bring to bear. What are some ways that one can manage stress from your family? I may need one of those myself. I'm not.
You would love our care managers too. They're fabulous.
Mine are pretty positive events, but nevertheless. And then over 3 months, the case manager interacted with Ms. K 6 times. So that means that every couple of weeks or so, Ms. K had somebody to say, "Hey, how's that strategy working? What else can we do?" And then her case was presented with the psychiatric consultant 3 times over that period. And this was not that the psychiatric consultant decided to see Ms. K. This was part of the routine model that is the collaborative care model. And so it was presented as part of that. And so and you probably won't be surprised to learn that I really kind of love this graph that Tisha made for us, to look at, okay, so her depression and anxiety scale started up here at sort of 16 and 17-ish respectively. And over the course of 6 weeks, dropped dramatically down to 0 and 4. And it climbed a little over time, but you can see that these are dramatically different and a dramatic improvement compared to where she started. And look at how many weeks we're talking about. We're talking about 15 weeks. And yet we said it took 67 days. So what's that? About 8 weeks, right? 8 times 7 is 42. No, 8 times 7 is 56. So it would have taken much longer for her to even get in and begin this process had she not had access to the service. So this is a dramatic example of how this worked well. It worked in primary care, and she received care and had improvement in mood. And I didn't even ask for numbers about physical health. My guess is if we looked, her physical health numbers would have started to improve as well. So, Tisha, let me just stop and see if you had anything you wanted to stress about Ms. K.
Yeah, I just want to say we have multiple stories that look like this. And also, I mean, I think from a cost perspective, it's important to think like collaborative care is the patient's insurance is charged once a month for the amount of minutes spent. So that means that if she had copays, she might have gotten 3 copays. And she did not see a psychiatrist, so if she got referred to see a psychiatrist, like that would have been a much higher copay and maybe out of pocket expenses. And the telephone calls were usually the average of our telephone calls. The first one is usually about an hour, but then after that they're usually 15 to 35 minutes. And so we're talking about small amounts of time, you know, uh, compared to if she had gotten the same number of visits or seen someone in specialty mental health. And you know, you couldn't ask for better results, um, regardless of what happened. So I think that can also be an important thing to think about.
And in a traditional model, she probably wouldn't have had 6 interactions over 3 months. It seems highly unlikely in a traditional model. So, so I just wanted to share this for 2 reasons: to show all of you the kind of results we're seeing here, and to also let you know that these are the kinds of information we're sharing with the state in order to share the impact this project is having.
Really
Okay,
good
and
to
so
see, Teresa, Tisha, it's good to see that y'all are sharing this with people in the state and people that don't already know what the collaborative care model is, and that you are getting some of the similar results that all, the 90 randomized controlled trials have gotten, and that show, speed to access, very, being able to take care of a whole person, and exactly what Tisha was saying, that it's lower costs, and it's been shown that it's, more likely to reach remission than even just having a therapist co-located in the clinic. So glad to see that you're getting some of this documented so that you can show it to people who are not aware of the model, especially Medicaid. Speaking from a Blue Cross standpoint, this is why payers want, the CoCM model implemented, because the total cost of care for these patients is going to be lower. So, Sarah, you popped on. Were you going to add in some?
It's just so exciting. Like, it looks great. Nice job.
it's one of the things that I've started to realize is probably the project needs, and when I say the project, this really falls on my plate, to really publicize what we're doing a little bit more in a more proactive way. And so I'm probably going to seek advice from many of you the best way to do that. But we're starting by, as I mentioned at the beginning of the presentation, that we're starting by trying to give our project a more formal name. I tried my hand at creating a logo, and it's okay-ish, but finally Kim, God love her, took pity on me, and is having some of the personnel there at ABIN take the bits I came up with and move them up a level so that they're more professional. So I'm really excited about that, because I feel like that's the obvious next step now that we've got some of the groundwork laid. And then I have one more slide for you. So one of the things that we're getting from SAMHSA, both in this project and another one I have, is, okay, so what? How are you going to sustain this, right? And I think that's a fair enough question, because that's what some of these projects are for. When we were writing this, I have to admit that I thought about this in a supply and demand kind of way. And I'm sorry that this had a dollar sign in it, because I wasn't thinking about dollars per se when I wrote it. Although, as we've just said, it's a very excellent use of funds. However, my thought was, well, from the perspective of having clinicians available in this state who know how to do this, and patients who've used it, and organizations, payers, as well as people who run clinics understanding this, we need to approach this by having both public and private clinic participation in the project. And so that's why we have UAMS, because we're the ones, when I say we, what I mean is Tisha and her colleagues, are teaching primary care and psychiatry residents about this model, as well as attendings and all the other personnel that are in the clinic. So I think of those of us here at UAMS really being sort of this public resource that are training clinicians who, for the most part, remain in this state. And so therefore we're training them. But if out non-UAMS clinics, and I probably should call it non-UAMS clinics, because FQHC are an interesting blend of public and private, but we're excited to bring on the River Valley Medical Wellness Clinic because it is a more traditional private clinic. And so we have those kinds of clinics participating. So now they're learning about this model, and going forward, we'll be looking for personnel who can participate in this model. So we have UMS teaching youngsters, and we have the clinics of Arkansas learning to use this model, and hopefully we'll be able to meet this demand by educating our students or our trainees. One of the other things that's going on, I put this in, we're going to come back to the issue of insurance reimbursement, because I wanted to point out the ways we are engaging the trainees is implementing CoCM in UAMS clinics that have residents are staffing them. So they are exposed to this model. The psychiatry residents, we're now offering optional rotations for them with our consultants, with our psychiatric consultants. And the UAMS is using psychiatric consultants with faculty appointments here, so that it kind of works well with residency requirements, et cetera. And then residents are invited to attend systematic case reviews with the psychiatrist and behavioral health case manager, so that they can see full circle what happens in this model. And then Tisha, I don't know how you do it, but Tisha has managed more than 100 presentations to residents. So I mean, this is astonishing, because it turns out she has other things she has to do besides this project. Go figure. So it's very exciting that we're trying our best to be sure we create this supply to meet the demand as we work with more I probably should say non-UMS clinics that aren't necessarily part of this teaching option. And then, as I just said, we're collecting outcomes. I just showed you some sort of qualitative approach to outcomes, but we're collecting quantitative data about outcomes. So soon I will start sharing those numbers with you as well. So that we can tell a story with how from a humanistic point of view, this is helping our patients. And then many of our clinical colleagues will be like, yeah, but Teresa, do you have objective evidence this is improving symptoms? And so we are in fact collecting that. And then recently, we've had a couple of inquiries about, gee, we would like to be affiliated with the program, but we don't necessarily need money to start. We just want to have access to resources and trainings and so on. And so I've been talking with Kim initially. Kim Schuler brought this to me, not the other way around. And so we're thinking about what could that look like? And I don't know if there would be time to discuss that at all today, but in any case, these are all the things that are underway to do sustainably. Now, going back to insurance, as Dr. Gibson mentioned a few minutes ago, all of the insurance providers in Arkansas, with the exception of Medicaid, currently pay for reimbursement. However, in working with Paula Stone and her team, she came to me and she said, look, I have to know what this is going to do to my budget so that I know how to approach this. And so we have, so we are working on pulling some data from the Arkansas All-Payer Claims database to demonstrate what we might expect, what Medicaid behavioral health budget might expect from turning on the codes to pay for this. And so I'm working with one of my colleagues in pharmacy, actually, Dr. Brad Martin. I don't know if any of you know Dr. Martin. He is one of the best. I shouldn't say this out loud because he'll get back to him. But he's one of the best analysts at thinking through how to do an analysis that will that can be directly used to impact policy. So so we are working on what that will look that analysis, and look forward to sharing that with Medicaid and others going forward. So I'm excited that we've been asked, gee, show the numbers. What can we expect? Because all of you, if you were going to make a big purchase, you'd probably inspect your budget a little bit, and so you would know what to expect going forward. And so we're looking forward to providing that. Okay, I'm going to stop and see if you have any questions for me. And forgive me if I've used up more time than I was supposed to.
I know the hours to discuss stuff like this, so it's great. I'm really happy to hear, kind of like what Tisha was saying with the patient profile that you shared. Those are common patients. Those are patients that come in every single day that wouldn't have necessarily talked about their depression symptoms. That absolutely affects their depression or their diabetes and their hypertension and that. So I agree. Those are patients that are being seen, 40 plus patients being seen by a doctor every day. So I'm glad that they are starting to be able to be caught in that net. I have my own questions, but I don't want to interrupt anyone. Does anybody have any questions for Teresa or Tisha on some of this information? Cool. I'll go first. I've got just logistics. I'm just interested. One of the things that you mentioned with the patient profile was there was about a 6-call average with her. Is that typically the average with your BHCMs? Are they able to get some of these results within that 6, or are you seeing more than that typically?
So I will probably have to let Tisha answer roughly how many visits her case managers are doing, because that isn't one of the metrics I track. That's maybe I should, but I don't.
Let me see if I can pull it up real quick. We have obviously stats. One of the
Sorry to
great
put
things
that on.
about the AIMS caseload tracker is that it pulls stuff. So it looks like our average weeks in treatment right now is 16.
Gotcha.
Now we're at different variable spaces with our different clinics. Some have not been as in as long as others. At 16, our average duration of a session in minutes is 27. 27 minutes is the average time we spend when we talk to a patient. And 87% of our patients have a current psychiatric consultation.
So Tisha, in that case I showed, we mentioned that over 3 months, Ms. K had 6 telephone calls. So that's roughly to a month. Is that kind of common, or is that more or less? Is that something you track? I don't know.
Yeah, the average, if you're looking at fidelity, like the fidelity to the way collaborative care was developed, every 2 weeks is the most common cadence. And that's what we ascribe to. If patients are more severe or need some more support, we'll talk to them once once a week. We also will talk to them multiple times a week if that's something that's warranted. But the average is every couple of weeks. We want there's like a thing on their list that says due if they haven't talked to them in 2 weeks. So 2 weeks is kind of the longest we want to go without talking to somebody. We will talk to them more frequently than that. But then we go into response prevention, or so once they're getting better for a consistent amount of time, then we put them in that model, and then we usually talk to them about once a month just to make sure that they're having the same, that that they're being able to maintain those low scores and the functioning, and then they'll get discharged. So that's usually why you'll see like that dip, and then they'll stay there, because we don't just you're good and kick them out. We follow them for a while, just to make sure.
Yeah. Thank you. I was just
Caitlin,
curious on that. Go ahead. Sorry.
No, I was just making sure that answered your question.
Oh, it sure did. And then one more thing that you said, Teresa, I think it was on outcome slide. It said there's an average 11-day wait for therapy. Is that an 11-day wait for the BHCM, or just a wait for if they were sent out to like a community therapist?
I believe that's BHCM, Tisha, unless I said it wrong.
No. So the way I calculated that is I basically took a year's worth of um our data, and I looked at the office visit that they got with the doctor, where what was when it was identified that they needed it, and then I looked at the first meaningful contact. So it could have been with our social worker or LPC that works in the clinic, or BHC. It could have been with our BHCM getting an initial intake, and or the psychiatric consultation. So it's just looking at patient identified, and then how long it took us to get a meaningful start to some sort of intervention with the patient. And but those are with us. It's incredibly difficult to track in our system if people get engaged in care outside. And a lot of it, I mean, there's a lot, if you look at our graph, it's like there's a lot of people it's the same day. A lot of people it's within 2 or 3 days. Usually those longer times are because there was a referral, and then we spend a week or two trying to get a hold of somebody. We start contacting them usually within 24 to 48 hours. There's no lag really in us trying to get a hold of them, but that meaningful contact means we actually had a conversation and like started a plan. So
Thank you. Okay, yeah, that's what I was wondering as far as, because I thought so too, is usually it's the warm handoff or within 24 hours or whatever. So, okay, thank you for clarifying that.
I was
Doc-
trying to compare the data that said, how long is it until you
yeah,
have get an appointment with a psychiatrist or a mental health professional. So
that makes sense. Dr. Gibson's internet went out, and so I don't think we're about 15 minutes late, so she may or have left, so she may not jump back on, but she was wondering if UAMS is billing yet. Has that started on your end yet?
I have so we've started a manual billing process. And it's quite tedious with me doing almost all of it. So I have sent a spreadsheet to the people who are supposed to key it in, and that is where we are right now. And that happened this week, so I'm going to follow up with Jason either today or early next week to see if they were able to do that or what the issue is. But for April, so I've got all the data for April, and it's supposed to be keyed in. And once we get that going, I'm going to go back to March and then to June and then kind of do that. But we're as close as we've ever been.
It's been a bit of a challenge because not from anything that Tisha's doing. She's thrown herself in the brink to help with it, but getting all of the forces to align so that she can efficiently put them through Epic has been a challenge at UMS. And so we've been continuing to, Tisha has been excellent at problem solving. I have been stirring the waters and just trying to fuss enough to get people to say, oh, we need to take this seriously. And with Tisha being the sort of the good cop and facilitating and me fussing, mostly Tisha, we seem to be moving toward a solution. So I'm really excited because because one of the ways we were able to plan for UAMS to implement this in all of the clinics was to put some money towards salary support in a clinic for a period of time and then move that money to the next clinic and so on, because we wanted to have enough money to support people for a bit and then get to the next clinic. And we wanted UMS clinics to be participating, but as I said before, we really want other models of clinics to be participating so that we can both train people and then develop this expectation of outside the walls of UMS, those people that hire UMS graduates, so that we have this supply demand. That is, the clinics expect to have these kinds of care available, and UMS has trained people to do that kind of. Yeah. Dr. Jansen, it looks like your hand is up.
It is for a fact. I'm going to try to make Tish's day. I can't make any promises, but maybe something that will make your job easier. I have a suspicion that Arkansas Blue Cross is looking very strongly at Epic Payer platform. And what that would do is would integrate us with the Epic systems in the state. And that might make your ability to move information, bills, documents back and forth, our ability to gather information from you. So stay tuned. I would say it's not a done deal, but it's looking pretty strong that we're probably going to be going that way.
Exciting. That's great news. Anything we can do to communicate more effectively.
I've never thought of fax as a 4-letter word, but I'm starting to think that way.
Yeah. And I think, one of the things is that because, and this is something that people across the country have struggled with, is that because the billing is a monthly conglomerate of lots of different touches, it's a different way of pulling things together. It's not just you do an encounter and then you through the bill. You've got to pull it all together. There's a lot of algorithms behind the fact or behind the scenes that you have to kind of do to calculate which is the right code. And so UAMS just really hasn't gotten that all figured out yet, but we're hoping. Right now it's my brain that's calculating it, so which is scary.
Oh my goodness. Well, that's very exciting. A lot of the stuff that you guys shared today is it's nice to go into the weekend with that. I think we all think our work is important, and it is, but it is nice to see it come together every month when we have these discussions. It's very encouraging, at least on my side. I do have a couple of just very simple ABIN updates. Are you guys okay with moving on to that for a few minutes? Okay. So like Teresa was saying, we've got McGee and River Valley Medical Wellness about to start. We actually are reaching out to them next week to schedule their training for their clinic and to start talking to them about the hiring process for their BHCM, and then to start to get their BHCM training also scheduled as well. So I know this has been a long time coming. We're really, really excited. I saw Dr. Martin last week when I presented at the DO conference, and she is just bursting at the seams, which I don't know how that woman has more energy to do anything else, but I'm so glad she's interested in this because she, with the population that she works with the high substance use disorder population she works with within our primary care clinic, I think not only are the work that we're doing right now is exciting, but also being able to put in the substance use disorder population as well into that intervention is going to make us Arkansas very unique in that, I think. So excited on that. East Arkansas is our shining star right now. They are working hard. We love them. They are such good people over there, and they are at the West Memphis location, their admin location. Kiara is their BHCM. She is doing great. Their original one did leave, so Kiara took on the entire brunt of the BHCM caseload, and she has done it gracefully. And they actually, I think they just made another offer to a BHCM. I think it's a social worker this time. So we'll be doing some training with them too once they get them onboarded. And then we are in discussions just internally as far as working with them to look at the next clinic they would like to deploy this to. We're kind of, getting things pretty solid over at the West Memphis Memphis location and comfortable. So we're looking at the next location. I think Dr. Ward Jones mentioned maybe Helena as the next place because I know it's her hometown and it really means something special to her. And we would love to do that. So just nothing has moved on that yet, but that is coming probably in the next couple of weeks, just as far as doing some of the demographic information and having the clinic fill that out so we can get ready for that. Okay, and then the last thing I just wanted to share is we are very excited about this, but we got accepted at CFHA to present on this program. And we are specifically, I'll tell you the name of the session because I don't want to butcher it, even though I wrote it. So, building trust and integration, lessons from implementing the collaborative care model. So, and we've got, it's really going to be more of a panel discussion, a little bit of a presentation, but a panel discussion with East Arkansas has agreed to come with us. And they're going to be kind of the biggest source of information on that panel, just talking about what it looks like in year 2. I mean, what it feels like to start, what it feels like to have those conversations with their clinical team, the pros and cons and kind of the bumps that come with implementing a new program into a well-established clinic. And then the Woven doctors are going to be attending as well, and then Kim will be there as well. So just we're very excited about the opportunity just to share kind of what we've learned so far, and really hopefully encourage others to take that leap. It is a scary thing, as we all know. It's a big thing to start. So hopefully they are able to ask their questions, and we're able to help some people out with some of that stuff. So I think I'm looking at my notes. I think that's what I've got for ABIN. Any questions on that? Anything I need to follow up on for that? Good.
Great work.
All right, everybody. I appreciate you. I wanted to say, if you have questions, concerns, or comments, please feel free to email me, or you can send them to somebody at ABIN and they know where to find me if that would be easier for you. But I'm happy to have suggestions, questions, comments, etc.
I did want to say there's 2 kind of exciting things happening at UAMS on this front. One is we have some dollars. We had a person who retired, and rather than fill their position, they're kind of reallocating those dollars. And part of those dollars, our service line has wanted to use to support one of our positions, our behavioral health care manager positions. So that just shows the dedication that UAMS has to this program. And another one is that we are bringing on a piece of a child psychiatrist to help support children and adolescents in our clinics. We're still kind of working through how we're going to structure that, but we're really excited about being able to do that too. So a couple of exciting things.
That is, you guys know I don't work with children. I've always done adults, so I know it. I'm always excited to hear someone else is doing that work, and I'm glad that you guys are considering bringing on child psychiatry. That'll be very interesting. The last part of that agenda is just upcoming events. I really don't have too many right now. Everybody's traveling. Everybody's got their own thing going on during the summer, so I don't have too many opportunities. Just the things that have been mentioned today. It sounds like there's a couple. There's the women's health that Michael mentioned. That's coming in October. And then Tisha, is it the Arkansas Psychological, or is it
Arkansas Psychological Association. And I put the flyer in the chat.
Yeah, and I downloaded that, so I'll make sure I share it. And then if you'll just keep me updated on the registration link, I'll make sure I include that in future postings. Does anybody else have any events that are coming up that you want me to make sure I send out to the listserv there? Okay. All right. Well, my boss is not here, so I'm going to give us 4 minutes back on a Friday afternoon.
We won't tell her.
All right. Thanks. All right, guys. Thank you so much. It's good to see everybody.
Thank you.
All right. Bye.